Saikumar sir. He doesn't need an introduction. He'll be talking about small pupils with pseudoexfoliation. Over to you, sir. No, sir. So, Dr. Minu, sir, please.
So since this is the first talk in this session, I thought I'll just have one slide on the different types of small pupils. We're going to discuss entirely about small pupils for 1 hour. I still remember maybe about 10-15 years back when you have discussed about small pupil, you will have one talk on small pupil and that is it. So now we have come to realize over the years that not all small pupils are not similar. There are different types that you need to encounter. So the first one is a routine senile myotic pupil. You see small white patches on the iris. The pupil doesn't dilate beyond about say 4.5 maximum 5 millimeter. But the patient is not on tamsulosin. There is no signs of IFIS. There is no signs of pseudoexfoliation. So that is a routine senile myotic pupil. You have IFIS where there is no telltale signs on the iris about anything, any of these myotic things. But you can anticipate it by the amount of pupillary dilatation, the duration of tamsulosin use, and sometimes the pupil dilates well and on the table you realize that this pupil is coming down and starting to flutter. The third type is pseudoexfoliation, which I am going to sort of slightly expand on today, where the findings are different. And you also have the uveitic small pupil where it is bound down by synic A, and because of that you have a small pupil. Now pseudoexfoliation cataract, other than the small or mid-dilated pupil, also has 3 or 4 additional things in it which you have to keep in mind when you operate. The first one obviously is zonule weakness. It does not necessarily mean that all pseudoexfoliations do have a zonule weakness, but you should keep in mind that this is a progressive zonulopathy. Even if during surgery everything is fine, these eyes over a period of 5 years or 10 years can have zonule weakness and decentration of lenses, dislocation and things like that. It has been shown in various studies that there is a definite endotheliopathy associated with pseudoexfoliation, especially the ones where the pseudoexfoliation material is, you can see a lot of material on the surface of the iris. There is a lot of material along the pupillary margin. These eyes definitely do have a zonule endotheliopathy. Shallow AC is seen in quite a few numbers of pseudoexfoliation, and as I mentioned before, the laid back decentration that you can have. The iris in pseudoexfoliation, just few points about that. It's actually a dilator malfunction. The fragility of the iris, which I consider is a very important thing. Now you have a very fragile iris in uveitic eyes. So the moment you release the synic A and just use a Coughlin hook to separate the pupil, just they get a lot of sphincter tears here and there, and the pupil dilates immediately. It's a very fragile iris. While the IFIS iris is very thick, it looks a bit boggy. We can start off know which are the irises which can go into IFIS. In pseudoexfoliation, it is somewhere in between that. If it is a moderate pupil or slightly more than that, you can manage without any devices. It does not myose progressively, unlike it does in an IFIS. It does not suddenly come down. If it is mid-dilated, sort of it remains mid-dilated throughout the procedure. If by some chance you have a zonule dehiscence and you need to use an iris claw lens, you can get small tears in the iris while you are trying to enclave it because of the slight fragility of the nucleus. So which device to use in case you need to use one? Any device which you are comfortable with, but capsule hook in eyes with significant zonulopathy, don't manipulate the chamber too much by putting in a ring. And Malugin, or if it's a very shallow AC also, it's preferable to have iris hooks compared to either a Malugin or a BH rings. We have fans of Malugin ring in this audience. So I'll just briefly just show 3 cases of 3 different severities. This was an eye where I did the rexis. There was a bit of zonule dehiscence, but after the rexis, I found that it was, the zonules were quite weak. I decided to go in with the capsule hooks. Now, once you use the capsule hooks here, the mid-dilated pupil can be slightly dilated, and then you can, once the hooks are in place, when you have that external tamponade or that hammock-like effect on the bag, then you can do all your procedures safely. Don't worry about whether I can hydrodissect or rotate. Usually it goes on very safely. and then the capsule tension ring is injected, and then you can go ahead with the IOL implantation. In this case, it was a single piece lens, and removing the capsule hook is slightly different from removing the iris hook because of the configuration of the tip of the hook. So you have to bend it slightly, and without causing any damage to the rhexis margin, you have to remove the capsule. This is a second case where the pupil is small. I actually did not expect this much of zonule weakness, so I decided that I'll stain the capsule and then go ahead with the Kuglen hooks and dilate the pupil and then go ahead. So that much I did, and after the dilatation with Kuglen hooks, this pupil sort of dilated pretty well. But once I started doing the rhexis, I found out that the entire bag was moving around. So I decided that I will put capsule hooks, but you cannot get the full 4 number of hooks in this patient after finishing the rhexis. So here you hook as you move. So you make a bit of rhexis, put 1 hook, then again do a bit more of rhexis, put the second hook, a bit more, put the third hook, and then do the 4th. So that way you can get a reasonably good capsular rhexis, and at the same time you can have good support of your tamponade of your bag also. So once that was done, this capsule was secure, and I went ahead with a routine phaco emulsification. Phaco was not part of this talk, and so I did not show the video. But actually, this patient, towards the end, we had the entire bag being, caught in the phaco probe towards the last piece. I could not save this capsule bag, so this went in for a secondary implantation. Now, this is the third case. This is the last one that I am showing. This is the jet black cataract, very hard cataract, where I tried, expanding with Kuglen hooks. It didn't expand much, and the moment I started doing my rhexis, I found out that the entire bag, large, huge nucleus, entire bag was moving. So I was not very keen on doing a phacoemulsification for this, because the specular count was also quite less, which is quite often seen in patients with pseudoexfoliation. So the moment I started doing the rhexis, the entire bag was moving, and this was something, so I decided to convert. So here I did a temporal tunnel, and you can see very easily you can lift, because the zonules are very weak. Just with 2 hooks, just like you take out a rhexis, take it out during an SICS, this entire nucleus came out, did a limited anterior vitrectomy, did an inferior temporal iridotomy, and went ahead and did an iris claw. So this in this sort of situation, I personally felt that this was the safest way in which this eye could be managed. So in summary, not all cases of pseudoexfoliation have a small pupil. You can have widely dilated pupils with all your target sign and everything you can see. Small pupil alone, handled with either stretch pupilloplasty, hooks or rings, whichever is your personal preference. In a shallow AC, hooks are better. Small pupil with phacodonosis, use capsule hooks instead of the iris hooks. And when you have a small pupil, a shallow AC, and a lot of pseudoexfoliation material, the chance for zonule weakness is very high. So always anticipate zonule weakness when you have a lot of this material on the surface of the iris. Thank you very much for your patient hearing, and thank you once again, Dr. Vanis.
Description and wonderful points that we could gather from there. Sir,
one question. Would you believe that you should do a PI for every iris clip IOL you do?
I would.
But I feel if you have done a good vitrectomy, I have not had any pupillary block, but yes, if the vitreous is not well removed, and then...
There are two categories. One is the iris claws, which you do late as a secondary procedure, where already vitrectomy, everything has been done. Suppose the nucleus goes down, you get a refer case from somewhere. Those things you can do without. But on the table, whenever I do, usually I do a PI. Because with a cutter, you can do a micro PI in a periphery without being seen. You totally take away the chance of having